Hey everyone, this is Eric Steinberg.
And Mustafa Syed.
Welcome to the EMRAds video series.
Let's go.
So our case for this lecture is a 77-year-old female with facial droop. She kind of looks like this person in the picture. You can't really see her hair here. Don't worry about it, Moose.
I'm scared.
Now we're all thinking stroke, right? But there are stroke mimics that exist, and we always want to keep them in our mind. Hypoglycemia, especially in alcoholics, may present with hemiplegia and aphasia. Mass lesions including tumors, subdurals, abscesses. Now usually these symptoms are gradual, but keep in mind people with mass lesions can acutely deteriorate in the setting of hemorrhage of the tumor or developing obstructive hydrocephalus. Todd's paralysis usually follows partial motor seizures, but can follow generalized as well. Usually the duration is brief, but it actually can last up to 48 hours. Hemiplegic migraines are rare, but they're another stroke mimic. The hemiplegia outlasts the migraine. MS can present as focal neurological deficits anywhere in the nervous system. And finally, there's crazy people out there, and a few of them like to fake strokes. Also, some people have something called conversion disorder. Remember the label indifférence, in which they lose function of an extremity, or they say they can't see for a while.
Sexy French accent.
Thank you. We always hear the phrase, time is tissue. And remember, we want door to treatment time in less than 60 minutes. Here's just a picture of what the AHA and the American Stroke Association recommend for evaluation of our stroke patients. Now, the NIH stroke scale is something we all should know in assessing a patient with a possible stroke. Now, for the sake of time, I'm not going to go over everything, but let me just tell you the 10 broad categories we should look at when assessing a stroke patient. These are level of consciousness, horizontal gaze, visual fields, facial palsy, extremity weakness, limitaxia, that's the finger to nose, finger, heel to shin test, sensation, language and aphasia, dysarthria, and extension and inattention.
For the specifics of the scoring system, you can check out mdcalc.com. The radiologic basics of stroke are pretty simple. Symmetry. The brain is a very symmetric organ. If things don't look like each other on both sides, they should be accounted for. Hypodensity. Hypodensity just means edema in the brain tissue for our purposes. Loss of detail, or definition, is another important sign to pay attention to. The brain is a pretty intricate structure. It has gray matter and white matter and a junction. Whenever you lose these junctions, or you lose the defining characteristics of the gray or white matter, you should be concerned about the possibility of stroke. Another sign that you may have heard of, commonly called the hyperdense MCA sign, or which can be generalized to any hyperdense vessel. The vessels become hyperdense for a number of reasons, one of which is that they have a thrombus in them, which results in slow flow, which results in an increased density on the CT scan. The most common one you'll encounter is the middle cerebral artery. Additional basics include the distribution. Always look at the distribution. Try to match the imaging you see with a good clinical exam. Strokes are generally divided as anterior or posterior. The majority of the strokes you will encounter are MCA strokes. Strokes generally have a timeline on CT. The ones we'll be concerned about are from 6 hours to 24 hours. At 6 hours, which is considered acute or even hyperacute, you have to look out for the insular ribbon sign and the hyperdense artery sign. At 12 hours, start looking for sulcal effacement and decreased attenuation of the tissue. That basically means the tissue starts becoming more gray. Between 24 hours and 2 days, you'll just see a lot of hypodensity, and that results in graying out of the tissue and the loss of detail. And we'll explain each sign with a picture. So here, what do you see? Take a look at the red arrows. You see that hyperdense line? That's known as the hyperdense MCA sign. Commit that to memory. This is something you'll see pretty frequently in the setting of stroke. If you look at the other images, you can see that on the middle image, there's a loss of gray-white matter differentiation over here on the left side. This makes sense because it's the left MCA that's thrombosed. If you compare it to this side, you see the strip of white, and you don't see it here. This is where symmetry becomes important. And the third example is just another additional example of a hyperdense MCA sign on the left side.
This is classic for a bad MCA infarction. There's loss of gray-white matter differentiation, I can't see any lumps or grooves representing the sulci or the gyri, and there seems to be some mass effect as well. And based on the timeline that we just went over, this should be right around the 12-hour mark or so. Again, knowing the distribution is key, as depicted on the image on the right. What are the arrows pointing to here, Moose?
This is a lentiform nucleus infarction on the right side. And this is pretty obvious. You can see the area of the lentiform nucleus right here, which is basically a gray oval. And if you look on this side, you have the internal capsule outlining the lentiform nucleus. This is the normal side. This is the side that's stroked out.
Now I'm pretty sure these arrows are pointing to where the insular ribbons should be, but tell us which one's abnormal here, Moose.
The insular ribbon sign can be pretty obvious and it can be really subtle. In this case, this is definitely one of the more subtle cases. If you look on the left side where these black arrows are pointing, you see basically a gray band extending along here. If you compare this to the right side, you can see that there is a gray band with a white outline. This is the gray-white matter junction at the insular ribbon, and it's lost here on the left side, compatible with a left MCA infarction.
Our job as the ED provider is to recognize specific ischemic stroke syndromes. The MCA syndrome includes both sensory and motor deficits involving the contralateral face, arm, and even the leg. Typically, the upper extremities are affected more than the lower extremities. This will be important when we compare it to other syndromes. Also involved in this syndrome is contralateral homonymous hemianopsia, which is depicted by the figure on the right. Finally, people with MCA strokes to their dominant hemisphere may have expressive aphasia, also known as Broca's aphasia. This is usually seen with the left-sided MCA infarct. This is because 90% of us have left hemisphere dominance. Almost all righties are left brain dominant, and about half of lefties are left brain dominant when it comes to speech. Another important point is expressive aphasia versus dysarthria. Expressive aphasia is characterized by the loss of ability to produce language, whether spoken or written. Now, it's different than dysarthria, which is typified by a patient's inability to properly move the actual muscles of the tongue and mouth to produce speech.
Okay, this is an ACA infarction, or anterior cerebral artery infarction. The anterior cerebral artery, as you can see, has a pretty medial distribution, and this is a classic example. You won't really encounter too many of these on the emergent setting. What you see here in the distribution of the anterior cerebral artery is graying out of the graying out of the brain parenchyma, and you lose the sulci up here, and you can't see the difference between the gray and the white matter. So we can place this stroke at past 12 hours.
The ACA syndrome can be similar to the MCA syndrome, with the main difference being that the lower extremities are affected more than the upper extremities. A simple way to remember this is to think of the term, put your best foot forward. Foot being the lower extremities and forward being anterior, as in ACA. Also, personality changes may be seen if the frontal lobe is affected. You know who this guy is on the right? That's Phineas Gage. He was a railroad worker in the 1800s who had a metal rod go through his face and into his frontal lobe. Phineas Gage influenced 19th century discussion about the mind and the brain, particularly the debate on cerebral localization, and was perhaps the first case suggesting that damage to specific parts of the brain may affect personality.
Eric Steinberg, you must have Phineas Gage syndrome.
What?
This is a posterior cerebral artery infarction. On the right, you can see the distribution here. For our purposes, just concentrate on the posterior part of the brain. And here you can see that there's intermittent areas of graying out, but you can still make out some of the sulci even though there's edema there. So this stroke is placed around 12 hours on the timeline.
Like the other syndromes we went over, the PCA syndrome can have contralateral sensory and motor deficits. Here usually the upper extremity more than the lower extremity. The visual field loss is described as homonymous hemianopsia with macular sparing, as you can see in the figure on the right. This is because the macula has collateral vascular supply. Memory loss, specifically anterograde amnesia, is seen in these patients. This is the inability to form new memories. Something more rare, but pretty cool, is visual agnosia and prosopagnosia. Visual agnosia refers to lack of recognition or understanding of visual objects. This is because there is a disruption of the pathway to the visual association cortex, which is our reference center for visual memories. For example, a patient may not recognize a set of keys placed in front of him or her, but would be able to identify them by hearing them jingle or by holding them. Prosopagnosia is the inability to identify faces. Usually this is a result of bilateral lesions. Alexia is another interesting and rare finding. Words are seen by the patient as if they are in a different language. If they're spelled out, or if the patient traces the word with his or her finger, he or she can understand it. Finally, ophthalmoplegia may be noticed if there's a cranial nerve 3 nucleus involvement. This will give you the characteristic down and out appearance of the patient's eye. Now let's not forget about two other important stroke symptoms that we do not want to miss. Posterior circulation stroke affect the cerebellum and brainstem. Symptoms we would see include nausea and vomiting, vertical nystagmus, and Horner syndrome, which is described as meiosis, ptosis, and anhidrosis. Also be on the lookout for something termed cross deficits. For example, left-sided facial weakness and right-sided arm weakness.
Lacunar infarcts account for up to 20% of the strokes. There are deep, small infarcts that result from obstruction of small perforating arteries that supply deep cortical structures. These are typically seen in diabetes and hypertension patients. Usually they occur rapidly and they can be fluctuating in a stepwise pattern. They're divided into 5 classical symptoms. Pure motor accounts for up to half of lacunar infarcts, defined as hemiparesis or hemiplegia. Ataxic hemiparesis is characterized by weakness and clumsiness on one side of the body. Dysarthria or clumsy hand syndrome is self-explanatory, the main symptom being clumsiness of the hand, especially when writing. Pure sensory is characteristic by numbness, tingling, pain on the side of the body. And there exists a syndrome that is a mix of both sensory and motor symptoms that makes it difficult to delineate from other stroke syndromes. Strokes in the posterior circulation, excluding PCA strokes, are difficult to visualize on CT, mostly because there's a lot of bone surrounding the area, which results in an extensive amount of streaking. Streaking is the white lines you might see going across the screen. This really makes it difficult for identifying the anatomy. As a result, if you really suspect a posterior circulation stroke, then I recommend getting an MRI, as it's significantly easier to diagnose it.
And these are one of the few times we get an emergent MRI.
One of the things you should be concerned about when someone strokes is the possibility of herniation. And this isn't limited to stroke. You'll see this in a lot of brain injuries. Herniation is basically when portions of the brain, due to pressure, start moving into areas they shouldn't be, and the resulting compression can be pretty much deadly for the patient. If you look on the left side, this area is known as the suprasellar cistern, the basilar cistern. These are collections in the subarachnoid space of CSF. When someone herniates, these are one of the first things that get occluded. Because there's so much edema, the pressure basically compresses these spaces. If you just concentrate on this space right here, and you look at this, you can see that it's occluded. If you look at this area right here, and you compare it to this, you can see that it's occluded. This is because of the large amount of edema that results from brain injury. And since the brain is closed inside a skull, there's nowhere for the pressure to go but down. This is another quick example of herniation. When you see tissue going across the midline, like this, and shifting the ventricles over, this is known as a subfalcine herniation. And in this case, it's the result of a subdural bleed.
As Mustafa said, brain herniations represent shift of the normal brain through or across regions to another site due to mass effect. Seen here are different herniation syndromes. For the sake of time, I'm not going to explain each single one, but here are the 4 most common. They are descending transtentorial, ascending transtentorial, subfalcine, and foramen magnum.
Another thing you'll commonly see in brain injuries is midline shift and mass effect. Midline shift is self-explanatory. Draw a line across the middle and see if everything's symmetric across both sides of the line. If it's not, there's some midline shift. What that means is that there's some edema, which is causing pressure, shifting brain tissue across the middle. Mass effect is also another self-explanatory term. It's a space-occupying lesion that exerts an effect, because of its mass, on structures around it. The example here is if you look at this ventricle and you look at this contour and you compare it to this ventricle and you look at this contour, it looks like this lesion here is pushing into the ventricle, narrowing it. This is the mass effect. The crossing of this tissue across is the midline shift. Hydrocephalus is another complication you should watch out for in brain injuries. The temporal horns, which are these little CSF collections, they're part of the lateral ventricles that you'll see in the temporal lobes, are very sensitive for hydrocephalus. What happens is, as CSF flow is blocked by buildup of edema or a mass, the CSF has nowhere to go, and it starts expanding the ventricles that it's sitting in. In this case, the temporal horns become huge. This is just another quick example of hydrocephalus. If you look, there's a mass here. It's shifting the tissue over, causing mass effect and midline shift, and as an additional bonus, if you look over here, this temporal horn is very enlarged. And so this person has hydrocephalus. And if you look at this bottom image, you can see the tissue shifting, going down and across. This is evidence of herniation. So, big things to look for in stroke. Is there blood or is there no blood? Look at the arteries. Are they dense? Is there a dense MCA? Is there a dense basilar artery? Always look for herniation, shift, and hydrocephalus in any brain injury, not just stroke. Some of the more subtle stuff, like obscuration of the lentiform nuclei, loss of the insular ribbon, loss of gray-white matter distinction, and sulcal effacement, are all early subtle signs of stroke. You really have to look hard, and you have to look for them and compare it to each side to be sure.
We can't talk about strokes without talking about TPA. The trials highlighted in green showed an overall benefit. The ones highlighted in yellow showed no benefit or no harm. And the ones highlighted in red showed an overall harm. Now, obviously, each study is different, and there are a lot of variables that go into our current decision making. Now, just a few weeks ago, the American College of Emergency Physicians took all of these studies into consideration and released its clinical guidelines regarding the use of TPA in stroke. For patients who present within 3 hours of symptom onset, ACEP gives a level A recommendation in favor of the use of TPA in ischemic stroke in patients who meet specific criteria, which we'll go over. Going further, ACEP gives a level B recommendation in favor of the use of TPA in the 3 to 4.5 hour window, who meet specific criteria based on the ECAS-3 trial. Note that the use of TPA in this setting is not FDA approved. So let's say you have an ischemic stroke patient who arrived to your ED within 4.5 hours. Can you push the TPA? Well, there's a lot of exclusion criteria, so be aware of all of them, or you could be doing more harm than good. On your patient's history, contraindications include stroke or head trauma within 3 months, history of intracranial hemorrhage ever, major surgery within 14 days, major bleeding, usually a GI bleed or a urinary tract bleed, within 21 days, or myocardial infarction within 3 months. Highlighted in yellow are relative contraindications for that 3 to 4.5 hour window, which are an age over 80 in combination with a previous stroke and diabetes. Clinically, exclusion criteria include spontaneously resolving symptoms, minor signs, seizure only if thought that the deficits are postictal, not from the stroke itself, if there's concern for subarachnoid hemorrhage, blood pressure over 185 over 110, even despite management, active bleeding, and also for that 3 to 4.5 hour window, an NIHSS stroke scale over 25. Finally, the following lab results are contraindications to pushing lytics: platelets under 100,000, a glucose under 50, an INR over 1.7 on a patient who's on warfarin, elevated PTT with a patient who's on heparin. Again, highlighted in yellow is a relative contraindication for that 3 to 4.5 hour time window. And for those patients, any oral anticoagulant, regardless of INR, is a contraindication for use of lytics in stroke.
So, do you guys remember the wild card? Let's give you another few seconds to take a look.
Ooh, the suspense. And the answer is Lemierre's syndrome. You guys knew that, right? So what is Lemierre's? Real quickly. It's a form of thrombophlebitis, usually caused by the bacteria Fusobacterium. Usually affects young, healthy adults, and it usually develops most often after a peritonsillar or a dental abscess. The reason being because deep in the abscess, anaerobic bacteria like Fusobacterium can flourish. They then penetrate blood vessels, neighboring jugular vein in the neck. The pieces of this infected clot break off and cause bacteremia and septic emboli. And they can go to the lungs and sometimes even your joints. Tell us what you see here, Moose.
What I want to draw your attention to are the vascular bundles. Take a look at the jugular vein here, this is normal, and the carotid artery, this is normal. And if you look on this side, there's a large filling defect signified by this darkened area inside the jugular vein. This is Lemierre's syndrome. So here, we have a lateral and AP chest radiograph of a 41-year-old female with shortness of breath and leg swelling for 5 months. If you saw our previous lecture on pneumonias, this should be a piece of cake.
Yeah, right. Then why is it the wild card?
I don't know. Thank you for watching the EMRADs series. We hope you learn a little bit about stroke and its imaging.
And as always, stay tuned for our next episode, which is on CHF.
Are you not entertained? Are you not entertained? Is this not why you are here?